We are live. So we are live.
Okay. Good afternoon, everyone. On behalf of AI Scientific Committee, I welcome you all for this Module 5 of OPMS One Problem Many Solutions. It's a video assisted certification course on Phaco in difficult situations. We have covered Phaco in black and white cataract, Phaco in small pupil, Phaco in post-polar cataract, and this is the Module 5th on Phaco in subluxated lens. We all know that these situations are really difficult to handle for any phaco surgeons, but we have today stalwarts and masters with us who know how to tackle and deal with these kind of cases. So I'd like to thank Dr. Suhas Sandipurkar, uh, who is master of all masters. We all have learned a lot from Suhas sir in our entire career. Thank you so much, Suhas sir, for joining us. We have Dr. Purinder Bhasin from Gwalior, who is an amazing surgeon who has amazing videos on subluxated cases. Welcome, Dr. Purinder Bhasin. We have Dr. Samresh Srivastav from Jaipur, who has so many innovations and international and national awards and innovations to his credit. Welcome, Dr. Samresh. And we have Dr. Madhu Udaraju from Andhra Pradesh, who is a prolific surgeon who has amazing videos to his credit. And we have today an expert panel with us, Dr. Ramamurthy sir will be joining shortly, Dr. Arup Bhaumik from Kolkata, Disha Eye Hospital, who has won so many international awards in ESCRS, ASCRS, and so many innovations he has done. Thank you so much for taking out time, Dr. Arup. And we'll be joined by Dr. Shobhit Chawla also soon. And thanks to moderator of today's session, Dr. Karan Bhatia, who is from Meerut, UP, and a prolific young surgeon who has amazing surgical skills. And we have Dr. Aarti Agrawal who will be joining shortly. So over to you, Dr. Karan, for the session.
Thank you, Harshul sir, for this wonderful opportunity. It's a fantastic webinar that we have today, as sir said, phaco in subluxated lenses, and this is a topic which is always a challenging situation for the young and experienced at the same time. Every case has its own challenges and own difficulties, and you need to go for a customized approach in such cases. So, without wasting further time, I will share my screen. And I would like to introduce the first speaker, uh, that is none other than the legendary Dr. Suhas Haldipurkar sir. Sir is a globally trained ophthalmologist who did his MBBS from KMC Hubli, post graduation from Mumbai with fellowships in Japan, Germany, and refractive surgery training in USA. He's a pioneer of phaco emulsification in India, a nationally recognized phaco teacher with his name synonymous with world class cataract surgery. He is the master clinician and surgeon and widely respected for his exceptional surgical skills and instruments as well. We all use the Haldipurkar forceps. He's the founder director of Lotus Eye Institute and the chief trustee of Lakshmi Charitable Trust. And he's a prolific academic and global contributor with numerous scientific papers, posters, and surgical videos. And he's an active presence in international ophthalmic forums. So I will hand over this to Dr. Haldipurkar sir to talk about the tips and tricks of handling subluxated lenses.
Thank you, Dr. Karan. Shall I share mine? So, Harshul, shall I share my screen,
Yeah,
please?
please, sir. Yes, sir. We are eagerly waiting to learn from you, sir.
Oh, thank you so much. Is my screen seen?
Yes, sir.
Yes, sir.
Yeah. Well, thank you so much, Harshul, for this beautiful invitation. And giving me a chance to be with some of those top guys in cataract surgery today. Today, my topic for young doctors is tips and tricks. Before I really take you through that, I would like you to just show you a case, which tells you, because sometimes the amount of the damage that has occurred to the eye can be deceptive. Now, this patient obviously comes with a history of trauma on the previous day, and there's not much of phacodonesis, but you know that this eye is a traumatized eye, and it needs to, like when you see closely, when you open and go inside, you realize that there are several things that are not okay. There is just a firecracker injury has caused him a trauma which caused rupture of zonules. It caused cataract formation. Then it caused posterior capsular rupture. So one has to be extremely, extremely careful if you want to really, hold that bag in place, want to do a in the bag implantation. You can see that posterior capsule is ruptured. But if your handling is very, very, gentle, you can preserve the vitreous phase. If you preserve the vitreous phase, you're not required to do anterior vitrectomy. Here you just noticed me put the endocapsular ring, which I put with a safety suture on top of it, because on the trailing eyelet, because in case this the the endocapsular ring decides to go inside behind the capsule, then you can always use that suture to pull it. So once that endocapsular ring is in place, now I decide, if you noticed it, because it's a little now the endocapsular ring is in place, and then the next job is to get one of these segments. Now this is Gupta segment. It's a beautiful segment which I get in, and I have used these Hoffman pocket. The advantage of Hoffman pocket is that you can make these reverse pockets, they are called, from the limbus backwards. And now what I'm doing is the segment is in place and the suture is taken out of the pocket and it is tied and the knot is buried in. Now the lens is going, it's right now in the AC, and very delicately the haptics are placed into the bag. Once they are in place, now it's time for you to do pupilloplasty, because normally these traumas cause traumatic mydriasis. And once that is done, you have circular central pupil, and this eye on post-op, it really looks very quiet. And on 12th day, his vision has come back to 612. I'm 6/9, which is definitely a good achievement for the kind of trauma this patient had. So let's go back to how do you kind of approach these cases. And now talking about tips and tricks, first and most important thing that we would do is to do pre-op evaluation, where it's a very important to know the cause of subluxation, the degree of zonular loss, location of defect. The location of defect will decide where you should sit and where should be your incision. Presence and absence of vitreous, it makes a lot of difference. If there's no vitreous, if there's no phacodonesis, then you are relatively on a safe ground. But if you have vitreous in the AC and there's a lot of phacodonesis, that means you have to be really prepared well for this case. Then you have to look for areas of missing zonules, how many clocks of zonules are missing. Then again, you can see for subtle sign, like sometimes when you don't even see the subluxation, but you know that the AC is slightly shallow or asymmetric, then it gives you a suspicion that something could be wrong. Should always ask for, you should proceed with caution when it's a high myope or a history of past plantar vitrectomy, or even a history of old trauma, which sometimes patient doesn't even remember. When it comes to subtle signs, You look for phacodonesis or pseudophacodonesis if it's already a pseudophakic eye. A wider iridolenticular gap will also tell you, or sometimes you may have very focal iridodonesis. These are the things we should really catch up before you start with your surgery. Then when it comes to intraoperative signs which are suggestive of zonulopathy, this is a typical spider sign. This classically tells you that the zonules are weak generally. So here, when you want to do a rhexis, it's very difficult. At such times, you may even have to use a sharp tip to make a puncture, and then you can carry on with. Then again, when you proceed with the surgery, you may have poor rotation of the nucleus after hydrodissection. These are some of the signs. Then the mainstay when you have subluxation is how are you going to fix the back? When it comes to fixing the back, there are two things. One, you need hooks to fix the back, and after the hydrodissection and nucleus is removed, you'll have to have a 360-degree fixation of the back, and that's done with your endocapsular ring. These iris hooks which are used for expanding the pupil, they can also be used for fixing or keeping the bag open or holding it, or it's better to use capsular hooks because capsular hooks are less traumatic to the bag. When it comes to endocapsular tension ring, it comes in different sizes, and based on capsular bag dimension, you can use a smaller ring or a bigger ring. And it's always better to have an overlap the end terminals to provide complete circumferential support. And the most common CTR that is used is 13 millimeter diameter. And corneal diameter is an indicator of a capsular bag size. Now, if you look at this, here the two, this is an old video of mine where in a bag which had a lot of zonules missing, the cataract surgery is already done. And with 4 iris hooks, the bag is literally held firmly. But at this stage, you will definitely need a 360-degree support inside because the hooks are going to come out. And this is where I'm using a Sionis ring. Sionis ring is one-step procedure where endocapsular ring and the fixation of bag both are done with the same ring because this particular CTR has one extra additional eyelet which can be used to fix. And normally you locate it or position this Sionis ring in such a way that that central eyelet comes where the maximum capsular instability is. So in a way, sometimes you feel that this is a little traumatic. And that's the reason these days I use less of these Sionis ring. But what I prefer to do is use an endocapsular ring, get a 360-degree support, and then, like you saw it in the previous case, use a segment because segment gives you much better support on the capsular bag and it can be placed in the most desired position. When it comes to capsular tension ring, it all depends on how much of zonular weakness you have. If you have less than 90-degree, CTR is an option, but when it is between 90 and 50 degrees, CTR is definitely recommended. As the weakness increases, sometimes CTR alone is not enough, then it has to be combined with a segment. When it comes to surgical principles, your incision normally has to be made away from the subluxation, at least 90 degrees away preferably to help reduce stress on the existing zonules. The capsular rhexis is made in an area which is remote from the dialysis to help utilize the counteracting forces. And if there's extreme subluxation, you may even have to decenter the rhexis because after the bag is fixed in place, the rhexis would come into the center. When it comes to hydrodissection, it is performed carefully to maximally free the nucleus, thereby decreasing zonular stress while manipulating. And sometimes using 2 instruments to manually rotate the nucleus is also very effective because the bag is a little unstable. Now, this shows you how in a extremely subluxated case, even doing a rhexis is a big step. Now, when you use a needle to make that puncture, that is a time you assess. If you think I'm not able to continue with this rhexis, this is the time I will use hooks to stabilize the part that has been already, where rhexis is already done, so that you achieve a little bit of counter pressure. But in such cases, you use a dispersive viscoelastic and literally pack the anterior chamber so firmly that to some extent the subluxated cataractus lens is made little more stable. And here you have to be very, very gentle and gradual. And like in typically in this case, to get a gap between the capsule and the nucleus is also a tough job. So sometimes you may even have to use a needle to create a space there. Once you get a space, then you can do hydrodissection. And this space is very much required because you want to fix this lens with the hooks. As against that, now this is a case which had a trauma with childhood, because of which there's a big lens coloboma that has occurred. And if you notice, this is where the capsular fibrosis has occurred. And this patient has no vitreous loss and no phacodonesis. So that means it's a much easier case to do. If you do not have a phacodonesis and do not have vitreous in the AC, the case becomes straightforward. But in this, because there's a lot of fibrosis, I chose this technique, Zepto, because Zepto, in such cases, gives you a beautiful rhexis without much of stress on the remaining zonules. And because this is a case where the remaining zonules are strong enough, I took the daring to continue with the case even without use of hooks. But after that, you would certainly need an endocapsular ring to put it so that before you put your lens, you need a 360-degree stretch on the capsular bag. And in this case, I felt that because the rest of the bag was stable, I could do without fixing this bag. And that's the reason after that, the only thing that I did was do pupilloplasty because the lens was slightly decentered, but it seemed to work well for that particular case. So continuing with that case, now in this case, which I showed you earlier, unless you put hooks, you cannot proceed. And to get your first hook into the bag is a difficult job. And it requires a little bit of manipulation because now this is an old case. If today I would use a capsular hook, and with the capsular hook, with the angulation that it has, it's much easier to hook onto the capsular axis margin. But this was done a few years back when we didn't have good capsular hooks, and that's the reason. But sometimes what happens is you may need more than four hooks. And in this particular case, I've used four hooks. And once you have fixed the bag 360-degree and the bag is firm enough, you can carry on with your Phaco like normal. And this is another case, again, a soft cataract, but it's a long-standing cataractus and subluxated. If you look at that particular sign there, it's difficult to puncture it. That what it means is zonules are generally weak all around, but it's a soft cataract. So I'm not really worried much about the nucleus part, but I know one thing, that this bag needs to be fixed. And to fix it, the most ideal thing is to use your segment in the most, in an angle where maximum weakness is there. So I chose here to fix the bag with the segment even before proceeding with cataractus, the removal. And here I chose the ASIA anchor. Now, ASIA anchor also one type of a segment, which is like a paper clip. You can insert it into the rhexis that is formed there. Once the segment is in place, or once the anchor is in place, because the cataract is relatively soft, it's removed well. But at this stage, I realized that the bag is collapsing. So when the bag collapses, you have to have the two hooks to anchor it. And along with that, maybe you can put your endocapsular ring. The principle for endocapsular ring is put it as early as you can, and stay as wait as far as possible. Like in this case, I waited till now, but it's not appropriate to wait any further because the bag has to be stretched 360-degree if you want good cortical cleanup. And having done that, the bag is fixed and the lens is placed. Now these are the capsular bags which are relatively small in size. So when the implant is placed in the bag, one has to be a little gentle enough. Now this is an toric lens. So once the lens is in and the viscoelastic is washed out, the lens is placed in its proper axis. Then the entire visco is washed, and finally the anchor is sutured. So normally it is proper that you anchor the suture at the end, because by then, the stretch of the bag is the artificial stretch which is caused by viscoelastic is removed, and you can place, suture the bag in the most appropriate location. Now, talking about, to summarize, the choice of capsular bag support will definitely be based on the degree of zonular weakness. If it's mild to moderate, CTR is 1. If it's severe focal or diffuse zonulopathy, then scleral fixation is the option. If it's tilted or decentered bag, decentered capsular bag, then scleral fixation is the way go forward. Any zonulopathies with phacodonesis, you have to use segment or anchor. And again, another classification would be based on etiology. If it's traumatic or iatrogenic, and zonular dialysis, even up to 6 degrees, 6 o'clock hours, only CTR may work. But if it's a generalized zonulopathy, then fixation with segment or anchor is a way forward. Do I have time now? If I have time, I can take this case.
No,
Otherwise, I
I
will.
think we'll take some discussion, sir.
Sure, sure, sure.
Yeah.
So
Thank
this
you
is
so much,
thank you
sir.
so much, Harshal, for the
Those
time.
are amazing videos, sir. Those are amazing videos, amazing teaching videos. I'm sure there's a lot to learn how to do meticulously these kind of cases. So we'd
Yeah.
like to take, yes, Aarti.
Yes. So I must say it was an amazing library of cases. And each and every participant who's watching this has so many keys and pearls to take back home. Thank you so much for sharing them with us. Dr. Harshal, sir, if I may take the discussion further,
Yeah,
can I please? Yes.
yeah.
We have Dr. Arup here. Sir, your insights on would you want to give throw some light on how to manage these subluxated cataracts for the young
So,
ophthalmologist?
so you cannot say anything more after Sar's video. We're watching and learning this video over the year. Almost 2 decades I'm learning video from Sar's surgery. Was one thing I must say, you everyone should prepare more when he dealing any subluxated case. So it outdoor it might looks very easy, but reality in OT table, it might be behave differently. So one must have full preparation to deal in any kind of subluxation. So this is the only thing. And the most important thing is capsular rhexis. Whenever you try to do the capsular rhexis, you should have at least 2 millimeter of fornix, so that it can CTR can fix in the equator, or whenever you fixing the bag with the Ahmed segment or Modus segment or any kind of segment or CTR, then Sionis ring, must have at least 2 millimeter fornix in the capsular bag. And only one case, today's sir also said that the Sionis rings better go for the CTR with the Ahmed segment combination rather than the Sionis ring. It is basically manipulation is much easier. Whenever you have a doubt that's your fornix or capsular axis margin is not 2 millimeter ideally, then you can go for better go for the Sionis segment rather than the combination of CTR IK Ahmed segment. Thank you so much.
Thank you, sir. Thank you so much. Dr. Ramamurthy, sir, your take on Zepto. There was this one case which Haldipurkar sir showed with the fibrous, dense anterior capsule. Sir has used Zepto beautifully. Any your insights, sir, on this?
No, I think it just shows Suhas's confidence with the machine. I personally do not have a Zepto, and I just had it for a couple of days for a demo. And because it was just initial days, I felt that I was causing too much pressure on the lens when I was using the instrument. So obviously, I won't be confident using a Zepto on a subluxated cataract because I'm not very used to the machine. But obviously, Suhas has great experience, and as all of you endorsed, wonderful videos, and he used it very well. I often prefer using if the patient is able to afford it, a LRCS platform on this. In these cases, if adequate amount of lens is exposed. And it's important in those cases to decenter the excess because the final position of the intraocular lens might be quite different from the subluxated lens that you're seeing. So decentering the lens, keeping in mind where the final position of the lens is going to be is to be kept in mind, and the ability to get a 5 mm or a slightly smaller excess in a decentered position with the LRCs is a great advantage. And if I may comment on certain other aspects, of course, everything was beautifully explained. Um, I think more than the CTR in the initial cases for stabilization of the bag, it's the capsular hooks which plays a very important role. And all of us have shifted over from iris hooks to capsular hooks. And though we all have old videos using iris hooks, and I think it's important for the youngsters here to understand that the CTR is going to offer only circumferential support. But as far as the stabilization of the bag is concerned, on the table is the capsular hooks, which plays a very important role. And as has been the dictum, which has been often repeated, introduce the CTR as late as possible, simply because once it's in the bag, then removal of the cortex, even epinucleus, etc., becomes a little more difficult. So oftentimes, if it is possible, I use capsular hooks 1, 2, 3, 4, depending on the extent, empty out the lens material, then subsequently use the endocapsular ring to circumferentially support the zonular support that is there. And as far as I think most of us have shifted over from combining a CTR and CTS rather than using a Sionis ring because it's much more easier to maneuver. And the indication for CTS, again, Suhas showed so beautifully in his table. For me, the etiology is also extremely important. If it is a case of sort of exfoliations, Marfan's, etc., where the zonulopathy is obviously progressive, then even if it's a mild subluxation, I would go ahead and fix the capsular back to the sclera, simply because over the lifetime of the patient, the entire bag lens complex could drop down. But if it's a traumatic cataract and where the lens seems to be fairly stable, I may not use a CTS. And the other thing David Chang has propagated, I find that it works quite well in my hands also, is that in the milder cases, using a three-piece lens with the optics of the lens captured and the haptics in the sulcus, that seems the lens itself seems to stabilize the back quite well. So apart from using a CTR or a CTS to stabilize, and especially if you just use a CTR and you want further support, and you are not using a toric or a multifocal lens, using a three-piece lens and placing the haptics in the sulcus and optics in the back is, of course, a great idea. Examining these patients preoperatively so that you know the extent of subluxation. Sometime on the table, it's the jiggling around of the lens is something that you notice, and I think otherwise everything else was so beautifully covered.
Thank you.
I
Please,
think,
Ashish, sir.
yeah. So, Ramurthy sir, one more thing, as Suhas sir showed that we all know that in these kind of cases, extreme subluxation and microsphericity is difficult to initiate capsular access, even the initial puncture. So, various techniques are used. I also describe one technique of using radio frequency capsulotomy probe of early Phaco machine. So it just makes a hole in the center and it doesn't put any stress on zonules. So whatever technique you use, either use a crossword or whatever you try to use it, the remaining zonules are weak, they get stretched. So in this, I just go there in center of the lens and give one burst and hole is made. Then you just snip with Caesar and then you can use iris hooks to give counter traction like that. So that's one thing. And I think Ramurthy sir rightly said that you can delay CTR, but capsular hooks in subluxated, you have to use in initial stages, because once the remaining zone will start breaking, or then it becomes problematic, especially in cases of pseudo exfoliation where cataract also is hard. So capsular hook should be the first one. 4 or 5 hooks should go and stabilize, because they act like artificial zonules, these capsular hooks.
Harshul, I have a
Yes,
small
sir.
question for Dr. Ramamurthy. Dr.
Sir,
Ramu,
sir.
are you listening, Dr.
Yeah,
Ramamurthy?
yeah, of course. How
Yeah.
can I not listen?
See, no. The thing is, see, like we've been in the past, if you remember, for these Marfans, we were little enthusiastic. We would, put an endocapsule ring, we would put a lens and leave them. Okay. Do you have a personal experience of any of these lenses that were done 20 years back, 25, having come back with lens back complex dislocation?
Absolutely, Suhas. I have had this, and even in
Plenty of, sir, plenty.
quite a
Plenty.
few.
No, I'm talking about not zonulopathies, about these specific Marfans.
Marfans, yes, quite a few, and that is the reason. Even if on table, if I find that the lens seems to be very stable, reasonably centered, I go ahead and put a CTS and fix the back to the to the sclera, because obviously in Marfans the zonulopathy is progressive, and over the lifetime of the patient, the support can go away and the entire complex can drop down.
Dr.
To be
Sopat, yes, please.
Can I ask a question?
Absolutely, sir. Please.
First of all, hats off to Dr. Suhas. As usual, a beautiful presentation. By the way, I learned my pediatric cataract surgery from him in 1997. I just want to ask what is your tolerance of persisting with these segments and CTR if the subluxation is 150, 160 degrees, or in the modern era, don't you think it's a much safer option to go ahead with a good lensectomy, vitrectomy, and implant scleral fixation? This is coming from my background as a VR surgeon. Second question I have is from Dr. Ramamurthy. When you off-center a femto in a sublux cataract, the rhexis, how do you feel is going to be strength of the rhexis for implanting a CTR? Do you feel ever radials forming because in the old generation machines, tags were an issue. In the new generation, after titration of power and timing, I'm finding it not an issue. And one more thing I want to add, if there is vitreous in the anterior chamber, and if the subluxation in a traumatic cataract is small, we can easily remove the vitreous through a 25 gauge incision and still go in ahead and try CTR. Thanks. Can I have answers?
Should we start with Suhas, sir, please?
Yeah. Shobit, it's so nice to see you after a long time. I haven't seen you. So I fully agree with you. In fact, the reason we don't get these Marfans are they all are getting referred to a VR surgeon, and lensectomy and scleral fixation is the way you all go ahead. But if a patient comes to me and if he's got a classic Marfans where the dislocation or zonular loss is, let's say, 180 degrees, I still have a tendency to go and fix it myself rather than. And what I see, the only reason I say that is because when I approach anteriorly, I just don't touch the vitreous at all, and I keep the vitreous body safe and intact and try and fix the back. And
Very good.
I mean, somehow that's the way I approach. But I have seen that the lot of these cases are today done by VR surgeons. And like you say, your approach naturally is to go from posterior, do lensectomy and fix the lenses by scleral fixation. Well, I have my own bias because I've done many of them, but I fully agree with you. That's what you said is the way forward, and people are doing it.
My other concern has been there are a lot of vitreoretinal pathologies like bad lattices with a little fluid around in Marfan's eyes. Most of the Marfan's eyes I've operated, even patients in their teens or more have come to me as only-eyed patients, where one eye had a scleral fixation, where one eye had, cataract surgery, and many of them had a detachment which was not repaired. So I find it safer option that I go ahead, lensectomy, vitrectomy in these cases, and try and do a 360 degrees endo laser treatment to avoid future issues.
Good. Yeah, I think that's the way forward. I guess.
I think very valid point, Shobit, in the sense that, but there's always a belief that there is an advantage of compartmentalizing the posterior segment from the anterior segment.
Yeah,
And we are able
totally
to
agree.
maintain the integrity of the capsular bag and fix the lens in the bag, then that would be a way forward. We see some dramatic surgeries, especially from Dr. Chi Soon Peik, where the lens is literally hanging in the vitreous cavity. She does for 3 hours, and she's a fantastic surgeon. Not many of us can emulate, but I won't even try to emulate her because I completely agree with you on that point. Such extensive subluxation, dislocations, there's no point trying to prove anything. I think the better way to go would be to remove the lens and do a scleral fixation. So many excellent techniques are available today. And as far as your second question of using a Rexis, decentered Rexis, I think you yourself answered the question in the sense that that was a concern with the earlier femtosecond laser, but now with a fluid interface or with a lens interface, and then less tendency for the aberrant laser spots, the postage stamp type of Rexis is no longer a concern. And oftentimes it's well established that the strength of the Rexis created by the femtosecond platform is as good as the Rexis created manually. And I don't want have had situations where the Rexis is given way because of endocapsular rings or CTRs or CTS or even the implantation of the intraocular lens. So I believe that the strength of the Rexis created by the femtosecond platform is no better than the manual Rexis, but no worse also.
Thank you. Thank you so much, sir. Just one thing, Dr. Suhas, sir, amongst all the amazing cases that you showed, the winner for me was the in the bag toric lens, which was implanted. Dr. Arup, sir, any insight from your end that can toric be easily planned in such cases, or the decision should be taken on table? Over to you, sir.
If we can fix the bag and center the bag with the CTS and or CNE segment, and I think toric works very good, and it is stable and it will not create. And the most important part is if you put the CTR in the bag, then chance of rotation of the lens also very less. So we can implant toric lens conveniently in these cases if we can fix the capsular bag well.
Thank you. Thank you so much, sir. So moving on to the next speaker, I would just like to share my screen. The next speaker we have is Dr. Purendra Basant, sir. Sir needs no introduction. Sir is a director of Ratan Jyoti Netralaya, Madhya Pradesh. Sir has keen interest in cataracts, Phaco, and I must say that he's a pioneer in his field. Currently the president of Madhya Pradesh State Ophthalmic Society and the president of Ocular Trauma Society in India. And also he's a managing committee member of AIOS MP State. So we are extremely excited to hear from you, and over to you, sir. Would you please share your screen? And sir is going to talk to us about traumatic subluxation.
Thank you, Dr. Aarti, for the introduction. At the outset, I am really thankful to Dr. Harshul and AIOS, Dr. Namrata Sharma, for giving me this opportunity of showing my cases and going ahead for management of the traumatic subluxated lenses. So I don't have any financial interest. Am I audible and my presentation is visible?
Yes, sir. We can hear you and your presentation is visible. Please go ahead.
So I will straight go to the cases, and this is case, 25 years old male had a closed globe injury with the cricket ball, and there was a traumatic subluxated cataract with vitreous prolapse and traumatic mydriasis. Vision was poor and the B scan was normal. And this is the case. As you can see, this part is subluxated, traumatic, nasally. And the vitreous is present, and this is very common with these kind of traumatic cataract cases. And we did an anterior vitrectomy before we started, and then we stained and checked for the presence of any more vitreous in the anterior chamber. Then we are proceeding for with the capsular access. So my say is that I use micro access forceps to conclude, and after initially puncturing the nucleus, the anterior capsule, and I fixed the lens bag with the capsule retractor. The case was young, so we don't expect too much of the hard nucleus. And polishing of the PC. When the capsule retractor is present, everything is within control. Now I'm removing it, and now I don't make a half-mite pocket. I make a scleral tunnel at 2 millimeter from the limbus, which is on bisided tunnel. And now, as I have removed the capsule retractor, so I have enough space for the needle to pass in, and I am supporting my trailing needle, which is going inside, and by the iris spatula. So I've used Sione ring, so this saves my time of placing two things inside. Although, I mean, I've used CTR with the CT segment also. Now here you have to titrate the bag. This is very, very important so that the bag is neither too loose nor too tight. Otherwise, you can damage the zonules further. And at the end, the lens is very well in the bag. I'm checking for the presence of any vitreous strands. And now, one more thing I have done is because of the traumatic mydriasis which was present with the irrigation aspiration or with the eye vitrector, I have reduced the size of the pupil to not the very small size, but definitely it is less than the size which will decrease the glare and halo to the patient, and lens bag is stable and the conjunctiva is cauterized and the suture is buried within the scleral tunnel. Another case with the 52 years old male with dislocated cataract with the nasal zonular dehiscence, and vision was very poor. And all these cases, they have some or other associated problems like traumatic mydriasis or the presence of vitreous or vitreous degeneration or posterior segment pathologies. So this case is grossly subluxated. As you can see, it is more than 180-degree subluxated, and cataract is also dense. So my initial puncture is with the cystitome, and now with the help of the micro forceps, I'm completing my capsular axis. The important thing which should be kept in mind is that we should have this broad anterior capsular rim. Otherwise, the iris hooks or the capsular hooks, they will come out during the procedure. So to fixate the lens bag, I have used 4 hooks in half of the lens. So this is very, very important. And the phaco emulsification is done. As you can see on the other side also, the zonules have got damaged, so which we could see here. So I'm not. We can other option which we could do is we can remove. We could have removed the lens bag, but here I am using a double Sione ring. So here this Sione ring is fixed at 2 places. This lens bag will be because it is subluxated largely on more than 180 degree. So I'm fixing it at 2 places. So two proline sutures are used. Two different proline sutures are used. As I said earlier, remove the capsule retractor after placing the ring in the bag and guided by the iris spatula, because you don't want to damage the capsular bag by the needle, which is sharp enough, and it should not damage while passing the needle inside, or at the same time when the hub of the needle is passing and it suddenly bends inside and ruptures the posterior capsule. So the suture is passed and it is tied to the sclera. This way, I'm passing the needle through the opening, the haptic um, of the CNE ring, and this is pushed inside. The lens bag, one can use bimanual technique, because this lens bag should be distended with the help of the viscoelastic. The high viscosity viscoelastic is very, very helpful, and it doesn't come out. And whatever maneuver you are doing, you better do it through the paracentesis wounds. And similarly, on the opposite side, the needle, which is slightly bent, because we are going nearly 90-degree from the main bone. So, and the needle is tied to the bed of the scleral tunnel. Here you can see, and the proline suture knots are multiple knots are made, and it is buried in the scleral tunnel. So once the proline suture is sequestrated, it will not come out, it will not rub the conjunctiva, it will not erode the conjunctiva. The cortex is removed, which is a layer of cortex which was present on the posterior capsule. Now my lens bag is very stable because I fixed at two places, as you can see, and a three-piece lens is placed, and this will so well centered. The pupil is made round, and the conjunctival cautery is done. So this is the end of the case. So another case where we had used a double CONE ring, which was in the past, as you can see, the subluxation is large, nearly from this end to this place, and we have used a double CONE ring, and which is the post-operative picture. Now, as we were discussing, the use of Zepto was very nicely shown and by Dr. Suhas sir. And here I have used a femtosecond laser assisted subluxated cataract. This 32 years old lady, she came to us with this complaint of defective vision for last 9 years. Her refraction showed 3.5 diopters of spherical with 4.5 diopters of cylindrical power at 60-degree, and vision was improving to 612. So she came for the refractive correction, and at other place also she has been advised for the LASIK surgery. So, but when we saw and we did the tomography, where we didn't find any cylindrical on the of the cornea. So this cylinder which was coming as a refraction was through the subluxation of the lens. And on dilatation, we found there was a subluxated lens, and there was a nuclear sclerosis grade 2 with posterior subcapsular cataract. So retrospectively, she gave the history that she had a trauma 11 years back to the eye, and now she has developed this cataract. So we did a laser assisted cataract surgery, and you can see this is the area of subluxation or zonal dialysis, and we have reduced the size of the capsular axis because we have to make it slightly eccentric, or we should make it central to the subluxated lens. So this is the capsular axis 4.6 millimeter, which you can easily make in any laser machine you can decrease the size of the capsular axis, and you can make it at one side. So as the zonular dialysis was small, so I didn't place a capsule retractor or the CTR before. So, but when I was doing the phaco emulsification, the vitreous started coming from the area of bare vitreous, and then we had removed the vitreous and the cortex and the lead spatter with the help of retractor, as you can see. And Sione ring is placed to make the lens stable and in place, and a single piece lens is placed in, and it is very well covered with the capsular margin. So the most important thing is doing a capsular access, as has been said by the other speakers and Dr. Arup also. So, and if we can do it with the Zepto or with the laser, it becomes easy for us to manage these cases. This is the post-operative picture of the same patient. There's another case where we did a small size 4.5 millimeter size capsular axis in a grossly subluxated lens, and this also was managed by the similar way. So when the lens is subluxated and long back, the injury has occurred, so lens back gets deformed. The shortening of the lens back occurs in the area where the zonules are absent. So this is how this patient presented to us, and when with the traumatic subluxated cataract, and with the shortening of the lens bag and the absence of zonules in that region. So after making capsular axis central to the subluxated area, um, hydro dissection is done, and then the capsule retractors are placed at the area of the zonular dialysis, and the Sione ring is pushed inside. One can use CTR and then the CT segment to fixate the lens bag. And but here the lens bag was very short, very small. So I had to put, it was with great difficulty I had placed this Sione ring inside. I'm using a bimanual technique with one Sinsky hook. I'm pulling the CTR inside, and with the other Sione hook, I'm the Sinsky hook. I'm rotating the Sione ring into the bag and placing it into the bag. The most of these cases, the lens is not very hard. Nucleus is not very hard. You can do irrigation aspiration, and lens is placed inside the bag. I have used purposefully to stretch the lens bag. I have used a three-piece lens. So it's whatever lens is available. If your lens is very well stable and the bag is stable, and you are fixing the bag to the periphery, you can always use the single piece lens in these cases equally. So this is another case, post-traumatic. So important thing in all these cases is that the bare vitreous should be covered with the viscoelastic. A dispersive viscoelastic is very, very helpful. And so the grossly subluxated lens from this place to this area, and there is a grade 2 to 3 nuclear sclerosis. So phacoemulsification is done after placing the capsule retractors at the capsular axis margin and stabilizing the lens bag. And they act like a trampoline, these capsule retractors, and they pull radially like the zonules. So this is very, very important. If you put the CTR and don't fixate it to the periphery, then the vitreous will start coming further into the anterior chamber. So here I have placed the CTR early, as you can see, and because of the now because of over tightening of the CT ring fixation, I have created a zonal dialysis on the opposite side. So it was a difficult case. So my lens bag is there with the ring inside and the zonal dialysis of nearly 300 degree. So what I did is I released the Prolene suture, I released the ring, and then another Prolene suture with two straight needles. So they are passed within the haptic of the ring, and it is then gently fixated. So because of the presence of PCR also, as you can see, there is a PCR. So I did one thing, that I placed the three-piece lens in the sulcus. But if I and the optic is captured in the capsular axis, which was intact. So there is a optic capture, and the three-piece lens is placed in the sulcus. If I would have not captured the optic in the capsular axis, the lens would have slipped behind through the bare area where the zonules are absent and the lens bag is not there. So the lens is very well fixed. The lens bag is very well fixed to the and stabilized to the sclera, but the lens is now optic is also very well centered. So this is how the patient looked at 1 month post-operative, and this is the PCR, and this is the optic capture of the, and this is the Sioni ring, which is fixed to the sclera. So another case with trauma to in a 39 years old male patient, 17 years ago, vision is 4/60. There is a subluxation of cataractous lens with a traumatic macular scar. And we did, as you can see, there is a typical rosette cataract. And so the most important thing is to prevent further prolapse of the vitreous. The anterior vitreous space is covered by the viscoelastic. Dispersive viscoelastic is better. And then a capsular axis is done. Hydrodissection is next done. Release the BSS from the bag and try to rotate the nucleus as far as possible. And CTR is placed. It is glided in the bag. And the important thing here to be noted is that your bag and the anterior chamber should be filled with viscoelastic. That is very, very important. Now I'm stabilizing the lens bag with the help of the capsule retractor. And because the injury had occurred long back, so there is a nucleus sclerosis also. In this particular case, Phaco emulsification is done in a technique which is suitable to you. And all these cases are post-traumatic. The technique will be slightly different in Marfan's or in other zonulopathy cases or in a spherophakia cases. Here you have removed all the cortex from the lens bag by manual, and throughout the lens interior chamber should be filled with viscoelastic, and before removing the irrigation and handpiece, you should always fill the chamber with the viscoelastic, and a lens is placed in the bag. And at the end, you can see the lens is very well centered. The bag is also centered. There is a strand of vitreous which will be cut, and aspiration of the viscoelastic from the lens, the anterior chamber is also done. So another case with the vitreous in AC. Earlier, this was done a few years back. So I'm doing an automated anterior vitrectomy after doing the capsular axis, and then fixation of the lens bag. And it's a similar thing, but it's an old case, which we have shown in my other cases. So this is interesting case. And as I said, these all trauma cases are associated with some other comorbidities. Like in this particular case, there is a deficient iris, and we tried to put a CONE ring inside, but we failed. So, as has been said by Dr. Arup in the beginning, that we should have plenty of other things in hand with us, and because I tried to use CT segment, but I could not do it. But here I want to emphasize that as the iris was deficient in this region, so we had repaired the iris, and pupil has been made center circular and smaller, as you can see, and this part is covered by the upper lid, and now the pupil is so well circular with the single suture. So these things should also be done, and sometimes we get a subluxated cataract, and this is a particular case where we had a trauma and a corneal tear was there, which was repaired, and after 5 months, the patient came to us with the intumescent cataract. And in this particular case, there was a zonulopathy also present in this region. So we carefully, with the small paracentesis wounds, we are doing the capsular axis and with the microforceps. And because the capsule, the lens is intumescent, although it is soft, so the iris is deficient in this region. So these aniridia ring segments, they come in a pair. They will work in two ways. They will act as to stabilize the lens bag because of the zonulopathy in this region, and they will decrease the glare and halo of the patient. So after placing one ring, I place the lens, a single piece lens in the bag, and in a reverse manner, I am placed the other ring, the aniridia ring, into the bag. So the previous gaps of the previous ring are covered by the serrations of the second ring. So the glare and halo is also decreased, the lens bag is stabilized, and the patient is happy. So this is the post-operative picture and of the same patient. So with all these cases, I conclude, and I will say that we should use capsule retractors at the capsular axis margin. This helps to fix the lens bag to the sclera, to the place where it is required, and they act like the natural zonules. And they will prevent further zonulopathy. They will also prevent the vitreous prolapse, which can continuously occur. And that helps and reduces the stress to the patient and helps in safe removal of the nucleus and irrigation aspiration. So more the zonal dialysis, use more number of capsule retractor, or if you don't have the capsule retractor, you can use iris retractors. And in more than 3 clock hours zonal dialysis, we should use a CONE ring or CT segment or modified CTR. And these all CONE rings or CT segments, the CTR or endocapsular ring can be injected safely with the help of the injectors. They help and they facilitate us in a better way. And one should be prepared to convert to SFIL glued IOL or AC IOL or iris fixated IOL, and after doing the lensectomy, as has been said by Dr. Shobit Chawla. So these are very well done. So what I will say is that our ultimate goal should be, after all, is not a good death, but a good life to the very end. So our aim should be a well-centered uh, lens possibly in the bag, which has been taught to us, and there should not be vitreous in the anterior chamber. And if we can decrease the size of the pupil, that is also helpful. And if it is associated with other comorbidity, they also should be managed. I thank you for your patient hearing.
Thank you so much, sir.
Thank you for that wonderful talk. We will go a little bit shorter on the discussion because we are a little bit late as per schedule. So, a couple of questions, sir. First of all, there's a lot of young surgeons are watching this webinar. So, first question I would be, because you're doing a lot of Phaco in such cases, how would you change your Phaco parameters? So, what do you do with that?
Karan, with the experience, you can manage the parameters by your foot pedal. But definitely for the beginners, I will say that your aspiration should be low and you should go very slow. So your parameters should be low and you should go very slow. And all these cases are a bit, speed is also increased. But I work and throughout the chamber should be filled with viscoelastic. That is a must to do.
Ramamurthy sir, one question I have for you is that a lot of these cases of traumatic cataracts have traumatic mydriasis also associated with it. So, what would be your technique for doing such cases for pupilloplasty, that is, and why?
I think it's very important that the pupil is also attended to, the iris is also attended to. And the two techniques have already been demonstrated, like Subhash showed the fourth row pupilloplasty, and Purendra showed that iris segments being used, and you also get intraocular lenses with artificial iris in the periphery. They can also be used. But one of the problems with these is sometimes over time they leach pigment, and they can lead to glaucoma, uveitis, etc. So in case it's possible to do a pupilloplasty itself, that would be a preferred mode. But if the loss of iris is so much that there's not enough iris tissue, then you might have to resort to one of these devices.
So, any experience with the pupils, the artificial pupils? Have you used it, sir?
No, I personally have not used them.
Artificial iris, you mean to say?
Yes, artificial iris, artificial iris.
Yeah. No, I have not used it per se, but they are available and they should be used with caution because chances of glaucoma are there with these artificial iris. But with newer one, they don't. They say that it's better.
There is one company that makes it called Human Optics, but
Human.
they make it customized and it's prohibitively expensive. And they take about 6 to 8 weeks to custom do it. So
No, the Indian manufacturers.
Once I inquired about the cost, it's almost Indian currency. It is they want the picture of the other eye, and they match the color of the iris, and it will cost around 2.5 lakhs for artificial iris.
Moving on to the next question, sir, to Arup, sir. Sir, just for another young ophthalmologists that are there, regarding the choice of IOL, can you suggest whether when to go for a single piece or when to go for a three piece in such cases? When would you do an optic capture? And the last part of it, when would you implant? Would you implant a multifocal lenses or a toric multifocal in such cases if you can save the capsular bag and manage it properly with the beautiful way that Bhasin sir has shown?
See, for multifocal, I have a reservation because the long run there is some kind of contracture and there is a slightly decentration of lens. So then it will be really problematic for the patient. So I'll definitely avoid any kind of multifocal if there is a any subluxation. Even though I able to fix the capsular bag in bar operative, it looks very fine, even though try to avoid multifocal. Toric oil, yes, I'll go for toric oil, single piece if I can fix the oil. But in cases of all kind of pseudoexfoliation, whether it is a subluxation or that, I prefer to put the CTR in the bag and put the multi-piece in the sulcus and they capture the optics. So this is the standard dictum. And whenever you feel your bag, even though bag is fine, even though it is not actually properly, may get some kind of instability in future. So it is better go for the multi-piece in the sulcus and capture the optics.
Shobit sir had one question, sir. You had raised your hand, sir.
I just wanted to ask Dr. Bhaumik, what is the material of the human optic, that thing what they are manufacturing? And does it go through a small incision?
Yeah, it's a foldable thing. It's foldable thing. Absolutely foldable thing. And it can implant through the injector also. And you have to fix the base of the iris in the sclera. It's like you fix the your CONE segment or CTS segment. You have to multiple bites. But the problem is that you can these multiple fixation point you can damage the angle of the iris. So incidence of glaucoma is postoperative glaucoma. You have to be careful. There's a high, and in few cases there is a little bit peripheral corneal touch. Ultimately leads to corneal decompensation. So and the material probably it's a kind of silicon. Samresh, you can highlight this. It is probably silicon.
It's a
It
silicon.
is silicon.
It's a silicon, and it's made to look like iris, so it's like a meshwork.
Yes.
Much better than the acrylic ones we had earlier, the
Yes.
segments.
Mhm.
So a lot of people.
Sir,
eyes with
I'll
it.
ask another question to Shobit sir, and then we'll move on to the next speaker.
Yeah, go ahead.
So, sir, a lot of cases of these require vitrectomy. Again, both the speakers have shown that beautifully. So, tips for anterior segment surgeons, would you do in such cases where there is vitreous prolapse with subluxation, whether traumatic or non-traumatic, would you do a pars plana vitrectomy or an anterior vitrectomy? And what tips would you give for anterior segment surgeons to do the choice?
I personally feel that today with cannulas, you have a much stabler anterior chamber if you put an infusion 3.5 millimeters to 4 millimeter from the limbus. 3.5 is normally safe. Then you go ahead and make your front one port and one behind. First go at the 25 gauge or 23 gauge, whatever you've made from the behind. After staining with triamcinolone, the prolapse vitreous, and do in that area of coloboma, where the area of the defect is. You get and plus make sure if there are zonules there, then go from the anterior part. If there are no zonules there, then you go from the posterior part and do a good vitrectomy. That will really ease your surgery of placing the ring also and make it very comfortable.
I do one thing, sir. Sometimes when I'm not, the ports aren't available. I have an anterior segment surgeon. I don't have the vitrectomy.
You can put an AC maintainer into it.
So what I do is I go about 4 millimeters. I take out, do a peritomy in about 4 millimeters, and I do a stab entry with an MVR. And then I go posteriorly with my cutter with the face up, and I do a vitrectomy then. And the infusion comes by the by the cannula of.
There is no harm in that.
And that does the
Only
work.
thing, your AC will not be that stable as
Yes.
would it be in the procedure I've told you. And you want the AC to be stable. You don't want to stress the remaining zonular apparatus.
In fact, I do that in my keratoplasty cases also when there's an upthrust. So after I put 4 or 8 sutures, I go behind to decompress the vitreous. Then I do a dry vitrectomy so that the anterior chamber gets deep, and then the surgery becomes easy. Otherwise, the lens will just pop out.
That is the surgery we do even now when we have an intraoperative hard eye. Not an expulsive, but an intraoperative hard eye. Just go ahead with a 25 gauge, do a little dry vitrectomy and go ahead with the procedure. Thank you.
Thank you, sir. So, thank you, Basin, sir, for that wonderful talk in the panel. We move on to the next speaker. And the next speaker is none other than Dr. Samresh Srivastav. He's an internationally renowned cataract and refractive surgeon. He's a pioneer in advanced phacoemulsification and premium IOL technologies, and he's the director of Raghudeep Eye Hospital, Jaipur and Ahmedabad. He's a healthcare innovator and entrepreneur. He's an academic leader and thought influencer. He's an associate editor of IJO and F1000 and review for iNature, JCRS, JRS. He's an award-winning researcher and educator with 30 plus publications, 470 plus citations, and global awards from ASCRS, ESCRS, and APACRS. And he will be talking to us about subluxation with iodialysis. Over to you, sir.
Your mic is on. Dr. Samresh, you need to unmute your mic.
Yeah. Audible now?
Yes.
Yes, thank you, Karan, for the lovely introduction. I am going to do a very case-based discussion because I think it's very difficult to chase two stalwarts, with any more knowledge. So I don't think I'll be adding anything more than what has already been said. But I'll put it in a perspective of one case that came to our clinic. This is a relatively young 44-year-old person who had a cataract following a spinal injury while doing some mechanical work. And this is how the patient's eye looks. I'm just going to pause it to show you that he has an iridodialysis, not an iridodialysis, he has a traumatic mydriasis. You really can't see the iris in these clock hours. And there is a limited traumatic subluxation or zonular loss running about 3 to 4 clock hours, and a diffuse sort of a cataract picture. Posterior cavity was not clearly visible, but enough to make sure the retina was attached. Now, when a patient like this comes into the clinic, like Dr. Shobit was discussing previously, and Dr. Ramamurthy had brought about, we have a few choices. We can go ahead and do a lensectomy and clear off this soft cataract, and then go ahead with the scleral fixation because it gives us ease of access and it's a quicker procedure compared to us trying to fixate this capsular bag. So before I go ahead, I wanted to show you that purely from a cataract surgeon's perspective, we wanted to understand what actually goes on inside the eye when we do a primary scleral fixation versus when we do a CONE or try to preserve the capsular bag. And so we decided to do an experiment a few years back where we broke up an operating microscope and mounted it upside down, as you can see, on a table, which was open at the top, where you put a human eye, which was transection and then fixed on a slide. So essentially, we're recording a surgery from the top, and we have a sort of a makeshift our version of the Miyake Apple view, where we're looking at the eye from the bottom to see what goes on. And very interestingly, when we looked at our capsular bag fixation, which is what our primary choice is as cataract surgeons to preserve the capsular bag, we realized that this is how the eye looks from the inside, where whatever lens you put inside the eye is well within the capsular bag. It's shielded from the ciliary processes, or rather the ciliary processes are shielded from the onslaught of these rigid haptics and this PMMA material, which is not biologically truly compatible to the human eye. So compartmentalization always preserves the anatomy and physiology of the eye. And with that in mind, we decided that in this case, we are going to try and fixate the capsular bag using my technique of fixating a CONE element. So like Dr. Purinder and Dr. Suhas has said, that you can make a reverse tunnel, but I like to make my scleral flaps old school. I used to do a flapless procedure using sutures, but then sutures can erode. So before the first thing I did in this patient was, before even opening up the eye or making any side port incision, I created the scleral flap because I want the globe to be tight so that dissection is easy and I don't go superficial or deeper trying to create an irregular plane. I've made only 3 side stab incisions using a 1.2 mm MVR knife, and I use bimanual technique of capsulorhexis. And as it's been elucidated, it's important to use capsular hooks. So these are MST capsular hooks because they're broader based hooks, unlike the hooks that we were using initially, because they have a good traction and a good hold. And I'm putting only the hooks in the area where there is zonular loss because I want the bag to be pulled on that side. I don't want the bag to be stuck up on all sides. Now, since this is a soft cataract and it's traumatic, you really don't need to do a phaco. So I haven't even made my main port incisions. And I keep my parameters very low, an IOP of 30 and a low flow rate, in order to gently take out this nuclear material. But at all time points, my irrigation is inside the capsular bag because irrigation is keeping the bag inflated. I don't want the bag to collapse. So I don't want my irrigation in the anterior chamber. I want my irrigation inside the capsular bag. And with that vector forces keeping the bag inflated, it's easy to take out the material. Always do a viscoelastic exchange when you are moving your hand. So you can see there is viscoat. This is not vitreous. This is viscoat that I had used to exchange my hands while removing cortex on the other side. And this is how the patient's eye looks once it's cleaned up. Again, to emphasize, this is the area of zonular loss on this side. And that's the area where I've held the bag in place using these capsule hooks. Now the idea is to fixate the bag. And we've seen it before in all the presentations. There are many techniques. I like to use a Sioni ring. So this is a Sioni CTR. But my suture technique, my suture involves the use of Gore-Tex. So this is a CV8 Gore-Tex, which roughly translates to anywhere between a 7.0 and a 8.0 Prolene. Nylon, sorry. And so this is what we are doing. I'm putting the element in the area of maximum subluxation. One trick is to make sure that the eyelet is above the capsular excess margin and not underneath it. And because there was a little bit of mix-up, I tried to separate both the suture ends separately. Once the Sioni element is in place, I remove the hooks because the hooks have absolutely no role to play. Now, what I want to highlight is instead of doing a railroading technique, one easy technique to do is to use a 25 gauge needle and make puncture wounds at approximately 2 millimeters or 1.9 millimeter posterior to limbus. So I cut off my needle from these Gore-Tex. I internalize a Gore-Tex suture and I use DMEC forceps, 25 gauge DMEC forceps to just go inside from the 25 gauge stab wound and pull out the suture. So it removes the headache of railroading and trying to maneuver your way into the eye. You don't even need a needle. You just need sutures. So one suture can last you quite a few surgeries. Look over there. I'm trying to get the eyelet out of the capsular rim into the anterior plane. Same thing I did with the trailing suture. So both the sutures out. I'm slipping because there was a little bit of a knotting inside. I slipped the knot from outside the Sioni element to make sure that there is no tangling, because if it tangles, your entire bag complex can rotate because there are tractional forces. And like Dr. Purinder said, it's very important to titrate your knot. So with the Gore-Tex, you cannot titrate it very hard. Otherwise, it will cheese wire through the sclera. Gore-Tex is an off-label use because it's officially not used for eye. It's used for pericardium, periosteum, and so forth. So I'm just gently titrating. I just want a knot. This suture does not lose its memory. So I just want the bag centralized. I'm not looking at making it a very tight knot over here. And this is me doing the second knot to make sure that I do a single knot, then a single knot, then a third single knot to make sure there's no slippage. And then I go ahead and implant a lens in the capsular bag. And mind you, this is the only time just before implantation of this lens is when I had made my main incision. Before putting the CTR. Up until then, I had not even made my main incision. I like to put a non-aspheric lens because even though it looks clinically centered because of titration, it never really is clinically centered. And you don't want to put complicated optics in the eye. So a standard spherical lens, a non-aspheric lens works best in these eyes. This was followed by suturing all the ports to make sure the globe was tight because this patient had a traumatic cataract and because there was a diffuse vidheme. It was taken over by my retina colleague who went ahead and did a full 3-port pars plana vitrectomy, which I would emphasize. So if you have a traumatic cataract, it's no point in doing a half-hearted attempt at just fixating the lens because there is pathology posteriorly, sometimes which is not visible. And so it's a good idea to go ahead and do a full thorough vitrectomy and make sure that there is no breaks, because if they are, this is the best time to laser them off. This is how the patient looks at the end of the surgery. Everything was sutured and the globe was tight. And this is how the patient looks at 15 days post-operative with a well-centered lens and Sioni element and the Gore-Tex sutures, as you can see. But the problem is this patient did not recover great vision because he had a retinal scar because of trauma. The problem is there was so much of a glare that he was getting socially anxious and everybody was complaining that there is a big reflex coming out of your eye. And although everything looked good, patient was not very happy. But I'll come back to that in a second, just to show you in 2 slides that we did a study a few years back on long-term outcomes on Sioni fixation in cases of subluxations. We published this also in a good study population of 30 eyes of 21 patients, in which there was a variety of traumatic and non-traumatic subluxations. But I'm not going to get in the details. What I wanted to show you that we were able to put a Sioni ring in almost 95% of the eyes. And at that time point, we were not using Gore-Tex, we were using Proline. And you can see the Proline sutures here. We were using Tenoproline, but then we moved on to Ninoproline because they were never lost its memory compared to Tenoprolines. And we found the patients had reasonably good visual improvement in these eyes compared to the primary treatment that was lensectomy done by retinal surgeons previously. And that the IOLs were centered in almost 90% of eyes, which was a very welcome result that we had. We had some complications, but more or less the outcomes were quite favorable towards this fixation. And that is why we held on to this technique up until now. Obviously, because the capsular bag is alive, you will have PCOs and you may need secondary procedures. But the good part is that in traumatic subluxations with 1 point fixation, you can go ahead and do a YAG because the other zonules are intact and they will hold the thing in place. So coming back to this patient once again, because the iris was missing in certain part, and because there was a lot of glare coming from the reflex of the IOL, we decided to go ahead and to do a pupilloplasty. So this is just trying to find out how much tissue is there, because there has been obviously a traumatic iris tear causing retraction. These irises will develop fibrotic membranes on them. So pulling is a good idea, with gentle pulling, not to induce an iridodialysis, but enough to make sure that the rollout of the iris happens well. And this is followed by a single pass 4-throw pupilloplasty that Dr. Amar Agarwal has taught all of us. So I'm not going to go into details of this. It's fairly simple, but the point is, it is actually a very simple procedure. It's not a difficult procedure. All you need to do is understand the dynamics of how to externalize the suture. And I think with one case, the learning curve is pretty much done. So once I sutured the eye over here, I realized that the pupil wasn't shortened enough. So then I went ahead and did a second pass to make sure the pupil was made even smaller. And the beauty of iris repair is that the pupils are actually quite round at the end of surgery, and they give a really beautiful cosmetic outcome. And if the patient's retina is good, even a good functional outcome. So this is how the patient looks 1 month after the pupilloplasty, and a fairly round pupil. And the patients complain of that, that glare coming from the eye when light shines on him is gone. And although the patient maintains a 636 part visual acuity, the patient is generally happy. So to summarize the cases in the interest of time, I think it's great to always look at the patient and plan and keep plan A and plan B in mind. I like to preserve the functional physiological anatomy of the eye during the surgery and also later, because the barriers have a role to play and they're not there for no purpose. It's always a good idea to stage your surgeries, because since the patient had a retinal trauma, we wanted to wait and see. We could have done the pupilloplasty in the first sitting, but we wanted to see the stability of the retina at 3 months. And once the retina doctor gave a clearance, we went ahead and shortened up the pupil, because once it's closed, you really can't see it except for whatever limited field of view you have. And we must emphasize to these patients, particularly the traumatic and the developmental ones, that there are comorbidities in the eye, and this is not the solution, and they need to be under lifetime follow-up. And with that, I conclude my talk. Thank you.
Thank you so much, Dr. Samresh. As always, it's a pleasure listening to your talks. And all the questions, whichever I noted down, I had an answer to all of them. I would just like Dr. Ramamurthy sir to give your insight on sir's talk.
I think excellent surgery, Samresh. Nothing less was expected. But we also used AONIs for quite some time. Now started using more a combination of seed, because you showed a beautiful study also. More for the ease of usage, in the sense that, when you diverse the CTR and CTS, then you are able to implant the CTR, and then you can even use an injector to place the CTR, and then subsequently use the CTS to hook the capsular bag onto the sclera and stabilize it. So I think that works well. Otherwise, and Purendra also showed the twin CTR. Those are little difficult to handle, but then I find that once you have the CTR in place, then fixing the CTS exactly in the location that you want, there's a different spacing between the two holes of the twin CTR. These things can be better controlled. Another observation that I want to make is, for the benefit of the listeners, is that CTR sometimes come with a large gap between the two ends, and sometimes when you have a large dialysis, the plastic of the PMMA of the CTR is abetting in that area. So I not only am particular about the size of the CTR being about 13 millimeters, I also make sure that they are almost a complete circle. There's too much of a gap, then the support for the capsular phonesis is not as good as what we want. And another thing is that you emphasize that also handling the pupil, which was also dealt with earlier, and tamponading the anterior vitreous space just in case it is necessary, and it's open with the dispersive viscoelastic, but at the same time filling up the chamber with the cohesive viscoelastic for your maneuvers, so the anterior chamber is quite stable is a good idea. And I am quite often when you have a PCR and I have to handle the vitreous, I go through the anterior route. But this is one place, if I find there is vitreous in the AC, then pars plana is the way to go, where I put a irrigation cannula in the anterior chamber, go through a pars plana route and do an anterior vitrectomy. Once the vitreous is stained, you can actually see the vitreous being drawn out and the chamber becoming very stable, and then the subsequent maneuvers become so much more controlled.
So, Dr. Samdesh, sometimes procuring Gore-Tex suture is slightly troublesome. So, for young doctors, any take, like, why did you select Gore-Tex over Prolene?
So actually, I mean, that's a great point. But my take on this is Gore-Tex is easier than using the flimsier sutures. Simply two things that make life easy. One is you can stop railroading. You need to invest in a DMEC 25 gauge forceps or like a 25 gauge straight forceps, and then cut off the needles. Just put the suture in that eyelet and put the suture end inside the eye, and with the forceps go and pick up the suture and bring it out. And because Gore-Tex is thick, it doesn't tangle. And because it's thick, you don't really need to worry about visibility and what's happening because it's pretty evidently there. And so what I do normally is, now if I have one large Gore-Tex comes as a very long suture, so you can trim it and sterilize individually and keep it, so you don't really have to waste suture, because it's difficult to get hold of Gore-Tex sometimes. That's the problem. But actually, it is the only thing is Gore-Tex suture knots can extrude, and so one has to be very thorough in making sure that they are under the sclera, because I've had quite a few patients where I had to remove the entire assembly because the Gore-Tex really came out of the conjunctiva. It will erode out. That's it.
So, Samresh, those are really very nice video which you showed. I think coming to the choice of suture, I was also using 90 Prolene, but then I wanted to shift to Gore-Tex because of the degradability of 90 Prolene over years. But somehow I also spoke to you and I was not getting Gore-Tex, so that made me shift to flanging 60 Prolene suture. So now in many cases I started using to fix CTS segment, or even to I use 60 Prolene. So just put in one of the end, flange it, and railroad the Prolene suture and get this out from scleral side and flange it. So it works very well and it's very cheap. 60 Prolene, you can have small sutures and it works very well those cases.
Anybody can contact me quietly later for Gore-Tex.
One last question to Dr. Sombit. Sir, you being a retina surgeon, what is your take?
Yeah,
like
I
when we
just want to congratulate Samaresh on his excellent talk and want to re-emphasize the point he said. If you have a subluxated traumatic cataract, you have a perforation in that same eye which has been repaired at the limbus or behind the limbus, looking at a proper vitrectomy in these cases, if you want long-term good prognosis of these eyes, is a must. Most of these eyes should be treated as badly traumatized eye, and if you are able to get out, along with this beautiful anterior segment surgery, the posterior hyaloid at the same time, it stabilizes these eyes for a very long term. Thank you.
So just one last question, Dr. Sombit. You being a retina surgeon, if at all in future we need a retinal surgery in the patients who we've done pupilloplasty, how simple it is to go ahead with the surgery?
I think there is no issue. If Samaresh would fix along with this, that thing, one with the wide angle non-contact viewing systems, you have a pretty decent view to accomplish a VR surgery today.
Thank you so much. Dr. Harshal, should we move to the next talk, please? Can we? So, in the interest of time, I'd just like to share my screen and introduce the next and the last speaker for today's webinar. It's Dr. Madhu Udaraj. Hello, Dr. Madhu Udaraju. Sir is a chairman and managing director of Dr. Ramana Raju Vision Tree, Vishakhapatnam, a fellow Arvind Eye Hospital, Madurai, and a refractive surgery accreditation receiver from Singapore National Eye Center. Amongst the many surgeries that Sir has done, one which needs mention is he's the first to perform Bowman's layer stromal transplant in keratoconus, first in India. Sir is a chairman, Scientific Committee, Andhra Pradesh Ophthalmic Society, and he's an advisor and Indian partner of Harvard Global Alliance of Medical Innovation. So we welcome you and we are extremely excited to hear your talk. Over to you, sir. And sir's topic for today is handling dangling lenses.
Thank you so much, Arti, for that kind introduction. My slides are visible, right? Can I go ahead?
Yes, sir. We can hear you and your slides are visible.
Yeah. So the scope of this talk would be under the following headings: a brief background, the causes of dangling lenses, how do you grade the subluxation, pre-op evaluation, protocols, and surgical trips. So if you see, I think the previous speakers have covered it so beautifully. So it makes my job much easier now. So we usually grossly do it into three categories. One is mild to minimal to mild, moderate, and severe subluxation. That is how you see in these pictures here. If you see, all this will lead to three things. That is decentration of the lens, phacodonesis, and instability of the whole visual system. So the most common causes that we see in our practice are pseudoexfoliation, followed by trauma, colobomas, post-vitrectomy eyes, eye myopes, hereditary disorders like Marfan's that have already been discussed, and also a prior intraocular surgery. So these are the things that we can use, as already most of the speakers have clearly mentioned. I'll not go into details, but the first one is the CTR. This is the Sienese ring, and these are the segments. And this is the capsule hooks for the interest of the listeners. I just wanted to show the pictures. So now I'll go grade wise. So when it comes to mild to moderate, that is when the jonular dialysis is less than 6 clock hours, the goal is to preserve and stabilize and fix the bag. The main thing here is to get your rhexis complete. It need not be circular, but you should complete the rhexis in whichever way possible. Your hydro procedure should be gentle. And once you finish the partial debulking of the nucleus, that is when I choose to place my CTR. I use iris hooks in place of capsular hooks just because I'm more used to them, but ideally you should use capsular hooks. And low parameter phaco, as the previous speakers have already highlighted. And if you're having access to the newer generation phaco machines, ideally you can control the IOP also during the surgery. 28 millimeters is what we put during the chopping technique, and you can go as low as 24 millimeters while you're eating away those pieces to maintain a very stable bag and prevent further damage in these cases. Cortex aspiration, I think you should keep the area of dialysis for the last. Place the haptic in that area and don't bother if there are some remnant cortical fibers also. They're harmless, and usually when they get fibrosed, they also prevent from this flaccid bag from getting pulled in again. So don't be very rigorous in cleaning your cortical fibers in the area of the dialysis. So whenever the dialysis is less than 3 to 4 clock hours, we can put in the IOL in the bag. And whenever it is more than 4 clock hours, we usually prefer to put it in the sulcus. So coming to a few cases that I'll show you now. Here you can see this is the area of dialysis, is almost 3 to 4 clock hours. So here, as I've told you, it's important to finish your rhexis. And once that is done, a gentle hydro. And now this is the step where I do differently. I prefer to put the CTR even before I start my phaco because it gives you that tautness and it will not allow further problems. And this is a very soft nucleus. So here I have used the iris hooks to tamponade the area of loss, and we can just finish the Phaco with minimal parameters here. And this is the most tricky part. And while removing the cortex, I prefer to use the Simcoe cannula rather than the bimanual. I feel it is more, it has more control in my hands when compared to a bimanual. And in these cases, as I've already previously mentioned, where the dialysis is less than 4 clock hours, you can intend to put it inside the bag. The IOL can go inside the bag. So this is one more case where you can see the dialysis there in this area, almost 5 to 6 clock hours there. Same technique again, gentle subluxation, gentle hydro, and then there goes your CTR. This is a bimanual technique where you can use the other dialer to guide this technique and make sure that it goes under the capsules, just stays in the equator where you rightly want to place it. So that's the bimanual technique. Once the CTR is there inside, the steps are again routine. So I'll just forward in the interest of time. So once you finish the cases, this again, iris hooks are used as a capsular support here, but ideally you should use the capsular tension rings. So this is where we have to be careful because CTR is already in place. So some fibers may be entangled there. Here again, oil is placed into the bag. And coming to the last case, this is a bit harder nucleus. And the whole bag was moving with an anterior kind of a dislocation. So here we could also see a strand of vitreous that was there in the AC. So here again, create some space for you to put your CTR. Once you have your CTR in place, make sure that, and now gently hold the capsular edges with the iris hooks. Finish your Phaco. Here you can see I'm doing the anterior vitrectomy in the superior part where you can see the vitreous prolapse into the anterior chamber. Here also, you can place the IOL into the bag again. So at the end of the surgery, there was that vitreous there and vitreous strand we were cutting with the anterior vitrectomy. And that final strand, you can vitrectomize it in the AC. So coming to traumatic subluxation, this was a blunt trauma case where you can see subluxation in this area, almost 6 clock hours here. And similar technique again. As the previous speakers highlighted, it's very important to give that counter pressure while you're doing the rhexis. It is not as easy as your regular rhexis. You have to be patient. And once you finish the rhexis, go ahead and support the lens capsule in the area where it is weak. And now again, placing the CTR even before I start my Phaco to make sure that it gives that horizontal tautness. And once you finish your Phaco, do your cortex aspiration. And here again, it's a traumatic midriatic case. So at the end of the surgery, once the IOL is placed in the bag, here because of the extent of the jonular dialysis, I'm trying to place the lens in the sulcus instead of the bag. During that, I have dislodged one of the iris hooks, so I can't do an optic capture. So still, I'll go ahead and try to place the lens in the sulcus. This is a 3-piece lens. So this particular area where you see conjunctivization was the area in which the primary trauma had occurred, and there is also some synechiae there. Just making sure that you're going in the sulcus plane. And once it's into the anterior chamber, to the center, and then dial the second haptic right under the iris. So once you have taken care of the lens, now you go ahead and try to release those synechiae that are there. Just pulling the iris towards the center so that the patient will have less halos and photophobia. That finishes the surgery. Now, this last stage, we have previously put a CTR, but the whole back complex has subluxated. And in this case, I think the best way is to do the complete bag fixation with help of the railroading technique that the previous speakers have already told you. Usually you take it 1.5 millimeter away from the limbus, create this limbal pocket, and then introduce your 26 gauge needle. Yeah, that's the 26 gauge needle. And from the opposite end, you can get your 90 proline, railroad it, repeat it with the second side of the suture, and then suture the entire thing into the, this is the second suture that we are taking. And once that is done, you just need 3 to 4 sutures there. So in cases of severe cases, I think it's better to plan for a complete removal of the cataract along with the bag. You can plan SICS or ECC as a primary option. You should always have a vitrectomy backup, and you should have whichever SF second IOL you're comfortable, the iris claw SF IOL or the CMT flex. So whom to convert from Phaco to SICS in these cases? Usually hard brown cataracts, we don't plan for a Phaco initially itself. And whenever you feel that you cannot complete the rexus, it is again prudent to convert to SICS. And as previous speakers have already highlighted, whenever there is a vitreous in the AC also, I would prefer to do an SICS. And persistent instability, despite all your stabilization techniques, that is also an indication for us to go to an SICS or ECC. Thank you for your time and attention.
Thank you, Dr. Madhu. I must say that you very well decluttered such a difficult topic, and your videos were excellent. We have Dr. Namrata ma'am join us. Welcome, ma'am.
So thank you so much. And I think this course on One Problem, Many Solutions, OPMS, which has been conceived by Dr. Harshul Tak. And this is a certified course which is going to be done by AIOS Scientific Committee. I would like to congratulate Dr. Harshul Tak and the entire team, including the moderators and you, for doing this so well. And we have 1,000+ registrations for this course. And now I think the best part is that it is on a module also. So in case you're not able to watch it now or answer the questions now, you can also take it up later. So thank you, Harshul, for doing it. And thank you to all the speakers and the panelists who make it happen twice in a week. This is done on Wednesday and Saturday. Thank you for watching and participating.
Thank you so much, Namrata ma'am, for giving this wonderful opportunity. And I think with this, we come to the end of the module 5th on Phaco in subluxated cataract. I'd like to thank all the attendees who joined on Zoom platform, on various Facebook and YouTube platform. And I'd like to thank all the speakers, all the expert panels and moderators of the session who took out time during afternoon from their OT time, from their OPDs to make this webinar happen. Thanks a lot, and see you all next Wednesday for module 6 on Phaco in intumescent and Morgandian cataracts. And I'll request all the attendees that please go on the link given and you can finish questionnaire which have been set up for you by Dr. Aarti, and you can take up those questions and get certificate from your scientific committee. Thanks a lot to each and everyone. Thank you so much.
Thank you. Thank you.